Thank you, Mr. Smith, you're recognized.
Thank you, Mr. Chairman. Certainly thank you to our witnesses. I think this is an important topic that we want to take on. The chronic disease prevention and treatment, I think, is actually one of the biggest challenges we face, as has been mentioned, certainly within the government payment context, Medicare, Medicaid, especially. And despite incredible success in research to help us better understand the causes of chronic disease alongside the billions of dollars invested in public health, overall rates of chronic disease have steadily increased. Alarmingly, some 129 million Americans, more than half of adults in our country, have at least one major chronic disease such as heart disease, cancer, diabetes, obesity, or hypertension. With nearly 90% of the $4.1 trillion America annually spends on healthcare going to treat chronic diseases, finding a way to reverse the trend is vital for our future, both for individuals and our country as a whole. While there are no easy solutions to the problem, it's clear more needs to be done to encourage people to actively manage their health in the form of regular care and prevention. The cornerstone of prevention is access to primary care and a strong relationship with the primary care provider. Primary care access is a serious challenge in rural districts like mine, which is why I have introduced legislation like the Critical Access Hospital Relief Act and the Rural Health Clinic Burden Reduction Act to support our frontline providers. We can also leverage successes in better coordinating care through utilization of accountable care organizations, or ACOs. In fact, earlier this year I introduced the ACO Assignment Improvement Act, which would make participation in an ACO even more accessible by allowing physician assistants and nurse practitioners providing primary care services the ability to assign their patients to an ACO without an extra doctor's visit. There's also significant opportunity to improve on the treatment side of the equation. Lack of treatment flexibility and outdated payment policies can often simultaneously cost Medicare more money and make it more difficult for patients to manage their conditions. Uncertain future payment terms can also discourage providers from investing in innovative new technologies which can more accurately diagnose chronic conditions and catch problems at earlier stages. The absence of a long-term reimbursement strategy also threatens breakthroughs in access to care like telehealth expansions. Most seniors were not able to connect virtually with their primary care provider for routine consultations and telehealth services prior to flexibilities developed during the COVID pandemic. Despite the popularity of these services among patients and providers alike, and one of the largest access to care expansions in recent history, effectively all COVID-era telehealth flexibilities are set to expire at the end of this year. While House committees have marked up various extensions, not even a short-term extension has been enacted, and both patients and providers still lack long-term certainties for the telehealth services they have come to rely on. Dr. Peters, I know you have a lot of experience working to address health disparities for those with diabetes. And I was wondering, how has greater access to telehealth services helped people manage their diabetes, especially in rural and underserved areas?
Well, it's made a tremendous difference because in diabetes we now have the wearable continuous glucose monitors, and those transmit the data to the cloud. So I actually don't have to have you in front of me. I can just look at your data and make decisions. And so we've been doing programs in our clinic where we just give everybody continuous monitors. And I can really improve outcomes. And that's both synchronous and asynchronous telemedicine. And we have a tracking system, we have remote monitoring, we check patients every day. And it really has helped enormously in my ability to reach those patients. Not everybody, however, in our clinic has access to the ability to do telemedicine. So we all worked all the way through the pandemic in person, but the people who can access telemedicine, it's tremendously beneficial. And I would be so sad to see it go away.
Thank you. Thank you. I appreciate that insight. Dr. Rinaldo, based on your experience with Medicare Advantage, how would you say plan design can better incentivize patients to build stronger relationships with their primary care providers? Any suggestions you have there?
Yes, absolutely. So in our benefit design, we often eliminate or reduce costs for preventive care services like primary care visits, especially those that are related to chronic condition management. So for example, we have our chronic condition special needs plans related to cardiovascular disease, diabetes, and end-stage renal disease. And specifically, for example, for our diabetic members, we provide services and benefits that include no-cost insulin and low-cost other drugs, no-cost diabetic supplies, and no-cost diabetic self-management training. For our cardiovascular disease members, in our Heart First plan, we provide $0 cardiologist visits as well as low-cost cardiac and pulmonary rehabilitation, and we provide no-cost primary care visits for these patients as well.
Very good. Thank you. I yield back.